Hi, and welcome to ID Talk, Answers from Infectious Disease Experts. I am Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I am the AzAAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of January 27th. So let's get into our questions. The first question is, whooping cough cases are 5 times higher than last year. Why do you think we have such an increase in cases? So this is a great question. Let's talk whooping cough for a few minutes. So whooping cough is caused by the bacterium Bordetella pertussis, and it goes through 3 stages. The catarrhal stage that lasts for 1 to 2 weeks, the paroxysmal stage that lasts 1 to 6 weeks, and the convalescent stage that can last for weeks to months. And it's that middle paroxysmal stage where we see those paroxysms of cough followed by the sharp intake of air that leads to that whooping noise. Now, it's important to note that little infants don't tend to have that sharp intake of air leading to the whooping noise, and they're also at the highest risk for having apnea and death. Pertussis is really quite contagious, and it's spread by droplets that are expelled from breathing and talking and coughing. And if you are a household contact, there's an up to 80% chance of transmission among those contacts. Patients are most contagious during the catarrhal stage, so that early stage when they have mild symptoms that may not be recognized as pertussis, but you can be contagious as long as 3 weeks through the paroxysmal stage. If someone has received 5 days of azithromycin, no matter what stage they're in, they're no longer considered to be contagious. In the 1940s, the wholesale pertussis vaccine was introduced and case rates dropped by 80%. There were problems with adverse effects because of that wholesale vaccine, and so they changed it and developed the acellular vaccine in the 1990s. And that solved a lot of the adverse effects problems that we've seen with that vaccine. The downside is that the immunity may not be as robust using the acellular vaccine compared to the wholesale vaccine. And we've seen that there's been some waning immunity over time, and so that led to the recommendation to start vaccinating our adolescents and our pregnant people. We see that with pertussis, it goes through epidemic cycles with peaks every 3 to 5 years. And usually in the pre-pandemic area, there were about 50,000 to 30,000 cases annually in the United States. During the pandemic, cases dropped to about 3,000 cases per year, and this is probably due to social distancing. But there may be the possibility that there were underreported cases because people didn't have as much access to care or testing during that time. As we've come out of the pandemic, case numbers have been on the rise again, and in 2024, there were 34,435 cases reported in the United States, and that was up from 7,063 in 2023. In Arizona, in 2024, we had 762 cases, and that was up from 344 cases in 2023. As I mentioned, the pertussis vaccine is 80% effective in preventing infection, but there are some caveats related to the timing of vaccination and type of exposure. We know that breakthrough infection can happen with close contacts of contagious people. They did a study in a daycare and showed that in that daycare where there was an outbreak, that 50% of the fully vaccinated children still got pertussis infection. So this is why it's recommended that if you are exposed to a contagious case of pertussis, that you get post-exposure prophylaxis, usually with azithromycin, regardless of your immunization status. So looking at all that, it's not surprising that pertussis cases are on the rise. It's probably multifactorial. We have an imperfect vaccine, and we have decreased vaccination rates overall. Plus, we're back to being in close contact with folks that may or may not know that they have pertussis. So keep vaccinating your patients and be on the lookout for pertussis. There's a good chance you're going to see it sometime in the near future. Okay, let's go to question 2. How do you combat the misconception that the HPV vaccine is a sex vaccine? This is another great question. And of course, no one wants to think about their children having sex. So it's understandable that some parents balk at the idea that we have a vaccine for a sexually transmitted infection. They're just not ready to even think about that stage of their child's life at this point in time. Let's talk about human papillomaviruses for a minute. They're pretty much ubiquitous. And at some point in time, pretty much everybody's going to get infected by one. They're a common cause of skin warts, genital warts, and many different types of cancer. The current HPV vaccine covers 9 different strains: 6, 11, 16, 18, 31, 33, 45, 52, and 58. The current HPV vaccines are really quite good. The clinical trials showed that they're is a 99% efficacy in preventing genital warts, 97% efficacy in preventing vulvar intraepithelial neoplasia, 96% cervical intraepithelial neoplasia, and patients have a 99% seroconversion rate. We also know that early vaccination leads to a better response. And so if you start your vaccine at 9 to 14 years of age, you only need 2 doses. But if you start at 15 years of age or older, you need 3 doses. The other important thing to remember is that infection can happen even without sexual contact. For example, infants can get infected through the birth canal when they're being born, and that can lead to skin lesions and can also lead to airway papillomas. The other interesting thing is that vaccination does not lead to increased sexual activity, and there are studies to prove that as well. So parents don't have to worry that just because their child gets the vaccine that they're going to go out and have sex. And one other thing to think about, which I don't usually bring up, is that someone can be assaulted at any time, and so it's nice to be protected if that were to happen. So I generally try to steer clear of the whole discussion of sex when talking about this vaccine, and that's just because that brings emotion into it that's not really needed for the discussion of why you need to have a vaccine. Of course, families may bring it up, and you certainly can discuss it in the context of what this vaccine does. But one thing that I do tend to focus on is cancer. Most people know someone and know the devastating effects of cancer. And so I really try to emphasize that this is a vaccine that can prevent certain types of cancer. We as medical providers understand the need to be protected against something before the exposure happens. When I was a kid, my father used to take us boating on the lake, and he was very much into safety and the law, and he taught us that if you were going to be on the boat, you had to be wearing your life jacket, and that would protect you. It didn't matter how good of a swimmer you were and how careful you were, you still wore your life vest. And that's because you never knew what was going to happen. Something might happen that threw you out of the boat, you could be knocked unconscious, and if you were not wearing your life vest, you were a goner. And I like to relate that experience to my patients. The time to put on the life vest is not when you're falling off the boat. The time is to put it on before you even have that chance. And so same thing with these infections. It doesn't matter when you're going to get exposed. You put your life vest on when it makes sense to do it. And in this situation, the timing to do it is 9 years or older. And that way you're protected before you have any chance of anything happening. Okay, so let's move on to question 3. I recently read that pre-infection vaccination reduced long COVID risk in children. Can you speak about long COVID and why only some patients experience it? This is another great question, and like a lot of the other questions, really does not have a great answer. So it wasn't long into the pandemic when we started realizing that some people got over COVID without any problems, and some people had residual symptoms, some of which could be quite devastating. And over the last few years, people have given it various names, but mostly have started to settle on long COVID or post-acute sequelae of SARS-CoV-2. So we know that there are a lot of patients that suffer some sort of symptomatology after their COVID infection. And these symptoms can affect really any organ system, and they can wax and wane, and they can last for weeks to months. And when you look at the literature to try to sort out who it's affecting and why, it's really hard to tell. And that's partly because there hasn't been a specific way to diagnose this. And so you can really imagine that there's quite a bit of heterogeneity as far as what's being labeled as long COVID and what kinds of things are being reported and what conclusions are being drawn from them when you look at the different studies that are out there. So because of this, the National Academies of Sciences and Engineering recently was tasked with developing a definition of long COVID. That way it could be used to assist with treatment and diagnosis as well as studies. So a few months ago they published their results, and if you're ever looking for something to pass the time, it's an interesting read. It's 166 pages, and they're really quite detailed in discussing their methodology and why they chose what they chose, and really explaining that they chose a definition that would fit, but also would be able to evolve over time as more data became available. So basically, the definition that they came up with said that long COVID is an infection-associated chronic condition that occurs after SARS-CoV-2 infection and is present for at least 3 months as a continuous, relapsing and remitting, or progressive disease state that affects one or more organ systems. Again, they note that it can manifest in multiple ways, can have waxing and waning severity, and can occur even after asymptomatic infection. It's also important to note that there's really no biomarker or test that can be done to confirm that somebody has long COVID. We know that there are some groups that may be at higher risk of long COVID than others, but again, it's hard to tell because of the variability of the data and definitions that have been used in the past. The big thing that's really important to remember is that long COVID can infect any patient. It doesn't matter how many times you've been infected. It doesn't matter what your age is. It doesn't matter if you have comorbidities or not. And it's frustrating because somebody could have done just fine with a prior infection with COVID, or maybe even several prior infections with COVID, but they may go on to develop long COVID with a subsequent infection. We know that children can get long COVID as well, and recently in JAMA there was an article published that looked at a cohort of 5,000 children from 2022 to 2023. The authors noted that 45% of infected children ages 6 to 11 and 30% of adolescents that were infected experienced at least one prolonged symptom after infection. They noticed that younger children tended to have problems with headaches and GI complaints, and that adolescents were more likely to complain of fatigue, myalgias, and memory problems. But there really was quite a bit of overlap in all the age groups. Now that being said, there are a lot of things that can look like long COVID and can overlap with long COVID and can complicate the picture of long COVID. So again, it's really difficult to know exactly how long COVID is affecting people. For example, in that same study in JAMA, that they looked at uninfected children, and they found that 33% of the uninfected younger children and 27% of the uninfected adolescents also reported at least one prolonged symptom similar to long COVID during the study period. So you can see it's difficult to interpret these studies, and you have to do so with caution. The good news is that we know that COVID vaccination can prevent infection. We also know that COVID vaccination can decrease the risk of developing long COVID. So yet another reason to stay up to date on vaccination. Of course, there's a lot more work to be done. We need to have a better way of diagnosing long COVID and trying to sort out what can be done for folks who have it. Okay, let's move on to our final question. Could you review the efficacy of the flu and RSV vaccines for this respiratory virus season so far? It's still too early to really be able to answer that question well, but I'll go over what I know. The influenza season starts in the southern hemisphere, and so we can look at data there to see if it will give us a hint on what we may be able to expect in our influenza season here in the northern hemisphere. We've got to interpret that with caution because of the principles of genetic drift and genetic shift can certainly affect which type of influenza virus we may see and may affect how effective the influenza vaccine is. The Southern Hemisphere published their data in October, which was towards the end of their influenza season, and they noted that the influenza vaccine was about 34.5% effective in preventing hospitalization. Now, there was variability depending on which category you looked at. So, for example, in patients who had comorbidities, there was a 58% effectiveness. In one country had an overall 61% effectiveness. So again, different factors may affect how well the flu vaccine may work. Here in the US, the CDC collects data on influenza viruses and compares it to the influenza vaccine. So what they do is they sequence the virus and genetically characterize it, but also antigenically characterize it to see how it compares to the current vaccine. As of last month, they had characterized 34 H3N2 viruses and showed that there was about a 55.9% similarity between those strains and the vaccine component for H3N2. All 14 of the H1N1 strains were similar to the vaccine component. They hadn't characterized any of the flu B strains because there were very few of them at the time. The CDC really does a good job of publishing their findings and data and surveillance on the FluView website. So if you ever have any questions, stop by there. You'll find out a lot of information there. But since, again, the data is early, they haven't published any information yet about the efficacy of the flu vaccine. Usually in February is when they start to publish that data, so keep an eye out, and hopefully we'll see that pretty soon. So hard to tell what all this means at this point in time. Certainly we know that we fluctuate from year to year, and this year may not be terribly different. Folks tend to say that on average, a flu vaccine will decrease your risk of illness by about 40% and your risk of hospitalization by about 60%. But regardless, we know that people who get vaccinated you usually have decreased morbidity and mortality compared to those who don't. So no matter how bad or great the numbers are, it's a good idea to get vaccinated. On the clinical side, it just seems like my colleagues and I are seeing a higher rate than we're used to of complications from influenza, and this is from the virus itself and also post-influenza bacterial superinfections. Maybe totally coincidence, but it's certainly caused me to redouble my efforts to inform my patients about how important it is to get influenza vaccine. Even when they're here for things that are unrelated, I still recommend that they get vaccinated. When it comes to RSV, there isn't a whole lot of new data out yet. Of course, people are looking at that and more information is to come, so we'll have to keep an eye out for that. But looking at the clinical trial data, it's really quite promising. So for nirsevimab, also known as Beyfortus, the efficacy at preventing hospitalization in infants was as high as 80 to 90%. And that was seen in the clinical trials and some small study, post-marketing data that's out there. When it comes to maternal vaccination during pregnancy, the clinical trials data was similar as well. So again, we'll have to see how things pan out, but it's really quite optimistic at this time. We are certainly seeing severe cases of RSV at our institution. A lot of them are older children, but we certainly have younger infants as well, and some of them were immunized and some of them were not. There are still quite a bit of barriers out there to trying to get immunization or vaccination, so we still have work to be done. Well, that about does it for this episode of ID Talk. Thank you again for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant Funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do. We'll see you next time at the next ID Talk podcast.